Good evening, good evening, good evening, and welcome to the Caring View, the first live Caring View of 2024. The fourth year we've been doing this, Mark. It seems like it's been forever, but it's been a very long time. So forgive me if I got on how to do what we do. We've had a nice little break off. I'm one of your hosts, I'm Pernell. I'm joined by my other host. Introduce yourself.
Hi, everybody. I'm Mark Tops. Good to see you all tonight. And yeah, we're joined by some amazing people that work in social care. So tonight we are talking about the Vivaldi social care project. But before we begin, I just want to do a round of introductions. So I'll start as it is on my screen. So Diane, I'm going to come to you first. You ever just to introduce yourself and the role that you're playing within the project?
Yeah, sure. So my name's Diane Mayhew. I'm the Rights Residents Campaign Manager at Care Rights UK. But I got involved with Vivaldi when Zoe contacted us because they wanted relatives input. I hope I've helped with various things like getting posters together. I managed to get a celebrity to do the voiceover for the animation. And it's been really good because, as you know, or for those who don't know, we've always been waxing lyrical about the fact that people in care, the voices aren't heard. And this has given me an opportunity to speak on their behalf and, you know, find out more about how we can help them moving forward.
Thank you very much. No, I'm really pleased. I know Adam and I have spoken many a time about the lived experience voice, so it's great that Vivaldi have got that all wrapped up. Zoe, going to come to you next.
Hi there, I'm Zoe Fry, and you have been absolutely fantastic, Diane, I have to say. So I'm Zoe Fry, one of the directors of the Outstanding Society Community Interest Company. I'm a nurse by background, and I've been involved with Vivaldi Social Care for the past 2 years now. The OS run the Adult Social Care Engagement Collective and training.
Thank you very much. And Samantha.
I doubly say you have been amazing, Diane, but you're amazing every day. So, you know, it's brilliant working with you.
Oh, thank you.
I love it. I love working with people I learn from all the time. So it's fab. I love it.
Likewise.
So I'm Samantha. I am the CEO of Bracebridge Care Group, also a director on the Outstanding Society. Slightly passionate about Vivaldi and research in social care, just a little. And I'm just very excited to get this project up and going, really, in care homes. It's a game changer, and it involves everyone, which is what it always should be. And yeah, I think we've really hit the nail on the head with engagement on this one. So yeah, very excited.
Thank you very much. And Mike, good evening. Nice to meet you.
Good evening. Thank you so much, guys. Yeah, really lovely to be here. Yeah, my name is Mike Slater. I'm a pharmacist by trade. Have worked with Zoe in care homes for about the last 10 years and have a real passion for care homes and forwarding progress for residents in care homes, and hence why I've been brought on for the Vivaldi project. I've got an interest in education, so I'm helping with the education side of rolling the project out.
Thank you very much. Nice to meet you. And last but not least, Laura.
Yeah, hello, and thanks so much for the invite. I feel like I'm the odd one out here a bit. So I'm a public health doctor by background, and I'm an academic at UCL. And I set up with lots of other people the Vivaldi study back in May 2020. But for probably the last 2.5, maybe we're getting near 3 years now, I've had the privilege to work with the OS, Zoe and Sam, and then more recently Mike and Diane too. And we've really been working together to try and learn from everything that happened in the pandemic and think about how we can all work together to try and reduce the impact of infections in care homes. And it's been absolutely amazing working with these guys. And we're managing to get a lot done, which is the most important thing. So yeah, it's been great.
No, definitely. Well, thank you very much for all joining. I'm really excited tonight because other than what I've kind of seen pushed out by the Outstanding Society, I don't actually know too much about Vivaldi social care and the project. So I'm on learning ground tonight as well, which is good. I know we've got a video that Zoe has given us to introduce the project. So I'm going to hand over to Adam to press play on that, only because he's the technical know-how.
You hold too much confidence in me, Mark.
We're all just sitting
Study
here
was
saying,
set up
thank
in
goodness it's not
2020
us.
to monitor the spread of COVID-19 in care homes. We've come a long way in fighting the virus, armed with a range of vaccines and a greater understanding of how it affects us. We now want to apply what we've learned to tackle other kinds of infections, like flu and gastroenteritis, which can make residents really unwell and cause outbreaks that could stop relatives from visiting. To do this effectively, we need data. What do we mean by data? Data is just another word for facts and figures, information no different to the records kept by the NHS about you, your health, and any treatments or vaccinations you have had. This information lets us build a picture of the nation's care home residents in our collective fight against infections like flu and COVID. It helps us understand how many residents have been infected, their body's response to infection, and the effectiveness of vaccines. We understand that this data is more than just numbers. It's precious and personal and needs handling with the utmost care. This is why it will only be seen by staff who have been specially trained and approved to protect confidentiality. The data will be anonymized before it is shared with researchers, and it will be kept safe and secure here in the UK, protected by independently assessed security systems equivalent to those used by the NHS. We want all care home residents to benefit, so we would like to collect information on everyone to avoid gaps in the data. We also know that not everyone wants to share their data. So you can opt out if you don't want to take part. It's as simple as speaking to your care home manager or Vivaldi's social care lead to let them know if you do not want your data included. With this data, we can continue to understand how infections such as flu, COVID-19, norovirus, and UTIs affect those living and working in care homes, and the ultimate goal of reducing infections, improving lives, and keeping our care homes open to family visits.
Thank you very much, Adam. So I guess that answers what Vivaldi is trying to achieve, but I hope that we can go and dive deeper into that conversation. So I think the first question for me is, it obviously started in 2020. Where did the idea and the concept come from, kind of those grassroots thoughts? I don't know who's best to kind of answer that, but I thought it'd be good just to kind of dive right back to the kind of the early stages and work towards kind of where we are now.
I suspect that's probably one for me.
Yeah.
So it was very interesting. Basically, there was recognition that there wasn't data on social care, no data from care homes, and increasing reports in the news, as you will all know, about the terrible things that were happening in care homes. And this sense that, well, if you don't know what's going on, it's very hard to know what to try and do to try and reduce the impact. And so we were asked to set this study up in a big hurry and to answer some very simple questions initially, just to try and get a sense of how many people had been infected, and to try and get some insight into the kinds of things that might be driving the spread of infection. So why were some homes getting outbreaks and others weren't? All with the ambition to understand what might work to try and reduce the spread of infection. And so to give you some examples, we were able to do work in a 6-week period by talking to care home managers. And we showed things like it was really important to pay sick pay. Care homes that weren't paying full sick pay were more likely to have infections in their staff. We found that in homes where staff worked across multiple sites, more likely to spread infection. So again, influencing the decision to try and limit the movement of staff across homes. So our focus was really about what can we learn quickly that's useful to try and reduce the impact in care homes. And that's really been our mantra throughout.
Thank you very much. Adam, any questions before I dive into my 101 that I've got in the back of my mind?
No, please dive ahead.
So I obviously, Adam and I were both managing different kind of services during the pandemic, both care homes. And I think you're absolutely correct that we obviously saw from what was coming out around staff sick pay, and I think we saw the government obviously introduce funds to kind of allow us to pay staff, and we saw that obviously the ban on staff working across multiple services and bits and pieces. What has been some of the findings that you've found, both from the early days and also now that you've collected a bit more data? And we'll touch on the data in a minute, but just kind of some of the outcomes that you've kind of seen from the study.
Yeah, it's been really interesting actually, because normally when you do research, you start off, you say, I want to answer these 3 questions in 5 years, and that's what you set out to do. Whereas with this, because the challenges were changing all the time, we had to be really agile. And so initially it was about, as I said, how many people have been infected, what might limit the spread of infection. But then the next big question was, can people get infected more than once? So before vaccines came out, people were getting infected. Everybody wanted to know, if I've been infected, am I safe? Does that mean that I'm not going to die from COVID? Or is it more like flu, where you get it once and then you get it again every year? And so we were able to show at that point in time, if you'd had it, you were much less likely to get it again. So quite reassuring. And then we helped to work out how well vaccines were working. Well, our study was the first to show how the protectiveness of vaccines for residents. And that was really important because all the vaccine trials didn't include residents. And we know that vaccines like flu don't work so well in that population. So there was a lot of concern. Great, we've got vaccines, but are they actually going to work? So we were able to show that they did. And so that was really reassuring, and also encourage people to get vaccinated. And then probably the third useful thing that we did was about variants. And so we know that everybody was getting very frustrated about lockdown measures, control measures. But as these new variants kept emerging, people were thinking, well, what does this new variant mean? Is it worse than the last ones? And so we were able to show, say, for Omicron, that Omicron wasn't more severe, it was less severe. And so that was reassuring for policymakers to say, actually, we can maybe start reducing some of those control measures. We don't need to lock all the homes down again, and so forth. So really trying to respond to the most important questions and get the right answers at the time they were needed.
Can I just come in there on that, Mark? I think the other thing is, when we were in care homes, because we were literally at the cold face, if you like, trying to make it all happen. I think the other thing that this showed us, and we hated it at the time, to be honest with you, because we were kind of a little bit tired and a little bit worn down by everything. But actually, this also highlighted where the team really affected transmission, as opposed to resident transmission, which was kind of a game changer, if you like, in how actually we were doing. I remember doing the RCAs with the health, the health teams, like trying to understand like what happened, but actually the impact of team members and transmission was huge. So we go back to that, when the government decided to pay people, but actually that was actually one of the biggest game changers in care homes, because it stopped an awful lot of transmission that would have continued through nobody's fault. And I think even when I first heard that, obviously I stayed in the care homes. I didn't go home, and it was very difficult because we didn't want to be the problem. We didn't want to be the people who were bringing this in, because we were trying to keep people safe and trying to keep people alive. But actually, this did actually show that was a big piece of I suppose a risk or concern that we had to really look at and kind of say, actually, yes, team members are actually more likely to transmit this to another resident than a resident is, and really own that and accept that, as hard as it was. But it also taught us as well, things like how we lived. We could adjust the way we lived as well as this was coming through. So I think that was another big one, Laura. I just thought I'd throw it in because it was very big from our perspective.
Yeah, if I can just very briefly, I don't want to hog the conversation, but yeah, it seems so obvious now, doesn't it? That you've got people wandering around in the community, they're interacting with loads of people. Of course, they're more likely to get infected. But at the beginning, everybody was saying, well, should we test staff? Should we test residents? We really didn't know, because it was all new and there were so many unknowns. So yeah, I agree with you. It was getting those critical pieces of information quickly, and then making decisions based on that. And that's what research is all about. So.
No, 100%. And Zoe, just coming to you, how did the Outstanding Society get involved? Obviously, with this project, with the study? Was it a case of Laura coming to yourselves or one of you directors, or did you see some of the research and think actually he's really interesting and want to be involved? Where did that kind of relationship stem from?
Sure. I remember it well, actually. It was in a March meeting, the CQC Trade Association meetings, and Laura came and did a presentation around what they had achieved, and my word, what did they achieve during that time? Normally research can take years and years and years, and we're waiting for results, but it all happened so quickly. So Laura approached the Trade Association meeting and said, if we can do this in COVID, why can't we collect data for adult social care going forward? COVID isn't the only infection. We've got DMV that closes homes. There are so many different things that we could look at. And the OS, we're very positive, we're very excitable. And so we put our hand up and said, yes, please, we want to come and work with you. And Laura mentioned at the beginning, she's the odd one out. She's definitely not the odd one out, because what this has brought together is academia, providers, and policy made fantastic. What this project is research led by social care, for social care, reducing infections and improving lives. And it's being co-produced. It's amazing. It's something that's not being done to the sector. We're doing it to improve the lives of people that we look after. So that's how our journey began.
No, thank you very much. And I know that throughout the course, so we've started booking events all the way up to kind of through to the summer. And I know we've got a couple of researchers joining us. It seems to be a big kind of area at the moment around social care, which is great, because actually we get all the data, we get those outcomes, and actually it drives that change forward. I was listening. Oh, go on, Zoe.
Sorry, yeah, it's such a passion. The NHS uses data to lead everything that they do, and we need to do more of that within adult social care. And so I think we're going to see more and more of it. It links to the quality statements. We need data in adult social care.
I think there's been obviously I'm no longer at the Institute anymore, but I did a lot of work at the Institute around trying to promote research in social care. There's still that stigma, though, isn't there, around social care providers getting involved in research. And I think, personally, for me, what we got from providers was there's so much of people taking the data and seeing nothing being done with it that people disengage and go, why should I get involved if nothing's going to happen? I would just quickly ask, what should we be saying to social care providers? How do we go, oh my God, get off your asses and get into social care research, because you get paid for it, for starters, money, woohoo. But what are the other driving factors we should be giving to people in social care to really sort of get their teeth into the research side of things?
Shall I come in? Let me come in. So as a provider, I'm one of those people, by the way. We kind of go, what we get now, this, is it going to make any difference in the next 10 years? I've got 3 million other things to do, and really, why should I bother, kind of thing, because I've got 3 million things to do and I haven't got time for this. I think the research as a whole coming into social care is fantastic. This, though, is the only project where we've got everybody all working together in the same direction. So this is unusual in the research that's out there. There's always been some form of research in social care. It just generally hasn't been questions we've asked. It's often questions that the NHS ask or someone else asks. But actually, these are our questions as opposed to questions that are being asked of us. I think for me, though, when Laura and I met initially, I was kind of saying, look, we need to make this as simple and as straightforward as possible so that it doesn't take time away, because we know we can't take 1 minute away from a manager or a team member in a care home. So I think I would say to people, we have a duty. We do have a duty. We're in this world because we care and because we actually want to make a difference. And if there's something that we can do to add to that, we should do it. I think for us on this particular project, we're able to say you can be involved. You can see great results really, really quickly. You can ask the questions that you want to ask. Laura knows I always bang on about UTIs and care homes and the impact of, somebody getting a 3-day course of trimethoprim instead of a 5-day course of nitrofurantoin, and whether or not we end up then with delirium and all of those things. we'll be able to go back to GPs and say, look, because you did X, this is what we're seeing. So we'll have actual data rather than, you know, if you ask any care home team, they'll say to you, well, this person doesn't do really good with this person ends up like this with this. But we don't have the data to prove that. Whereas this is real, true data. We'll be able to show what the impacts of decisions are. So I would say that be involved because you can ask the questions and you can get the answers to the questions you ask, which are the really, really key. And then again, the one other thing I would say is this particular project will not take time away because it's extracting data that we already have rather than asking team members to spend a long time filling out forms, doing this, doing that. We're not asking people to do that. And because that's often what puts people off, to be fair, because you just think I haven't got time for it. So I would say those two things would be why.
Can I just jump? Sorry, Diane.
No,
I'll be quick, I promise. So
No,
just
it's
two points. So one, when I started doing this project, I was absolutely shocked at the lack of parity between the NHS and social care. As somebody who'd mainly worked in the NHS, and literally looking around, it's like, this is nuts. How can it be? And then realizing, well, of course, a big part of that reason is that every time you want to do something in the NHS, you can pull out some stats. We need to improve hip replacements because there are this many people waiting, or the quality of care in this hospital, or you can't do that in social care. And you can maybe say, oh, we've done some interviews or we've done some small scale research, but no one will listen to that. If you want politicians to actually pay attention, you need good stats. And so through this project, we will have good stats, and that makes social care non-ignorable in a way that hasn't been seen before. And that's why we were able to get stuff done in Vivaldi, because we kept putting statistics there and saying, no, you have to do something about this, because look, here are the numbers, and they're big numbers. And so I think that's the key role that we can play here.
Zoe, did you want to come in there at all?
Just very quickly on the back of Adam's question. So going back to your question, why should care homes get involved? It's just come to me. Last week we had a care home visit. So a part of the project, we're visiting care homes once a month, and we're visiting care homes with UKHSA. So UKHSA have funded the project. We visited with UCL and the OS. We had no idea what we were going to turn up to. The manager was fantastic. She said that she's going to invite lots of people. It was amazing. We had residents there, we had relatives, we had team members. And the residents, Mike actually recorded what one of the residents was saying. He's given like a testimonial there. Why wouldn't we get involved as a care home? What can we do? And we've had a relative now join the Adult Social Care Engagement Collective, and they really championed it, and they were so excited. So if we've got people living within our care home saying this is amazing, why wouldn't a care home want to get involved? It's perfect. It was. Thank you.
And staff, actually, just off the back of that, Zoe, the guys that we spoke to, the team members that were there that day, were just all so absolutely 100% engaged with this. As soon as the kind of penny drops in the fact that actually what we're going to do here is change the way we can care for people for the better. It just transforms the way people see this, and it's just so simple. So yeah, it's incredible to watch that kind of transformation in people's eyes as they go, really, that's all we have to do, and we can get all that data. It's amazing.
Can I come in? So I was just going to say, when I was first approached to get involved in this, and I know I said this at the care show, but part of me was thinking, oh gosh, research, is it going to be another talking shop? Is there ever going to be anything at the end of it? And then when we all got together and everybody was just throwing different ideas, and I didn't even know that care homes didn't have data. I couldn't even believe it. And I know everybody is feeling that the NHS, well, adult social care is like the poor relation to the NHS, and it needs to level up. And I'm thinking this is just like a no-brainer, really. And certainly from the point of view of a relative, during the pandemic, when you couldn't get in to visit your loved one and you were watching them deteriorate through a window, this is a game changer, because the whole point of it is try and keep homes open rather than close them. And I think we saw during the pandemic that even when, if you had like a really large care home and they had COVID on one floor, but they didn't have it on the other floor, the whole home closed down, and there was no need for that really. And I think without this data, we're not going to learn lessons about what happened during COVID. But with this data, and I know it's moving really fast, even since I've got involved in it, it's this stuff happening all the time. And why, as everybody said, why wouldn't it? It's great for the relatives because they can visit. It's great for the residents as well, because their relatives can visit them. And also we're trying to keep infections out of homes. It's great for the staff. You know, I just think it's just like we've all said, it is a game changer, and it can't come quick enough for me.
I think sometimes as well, I think the word research and the word data, I think it's quite scary for us in the adult social care sector, because we haven't used it a lot. But talking to care homes, talking to teams, this is why we've all come together. And even at the home that we went to the other day, people were coming up with problems saying, well, actually, can we not look at this? So the residents, the team members, the relatives are coming up with a problem, and then the research will come up with a research question. Then we'll collect the data to see how we can make that better. So that's how the co-production is working really well, I would say, in terms of research data. This is what it actually means for the sector.
Do you mind if I just hop back in on that? Sorry. So two things. One is, the other thing is Zoe, I'm just going to quote you actually from your visit the other day, that you experienced outstanding when you were in the home. You experienced
Absolutely.
it. But also, you know, we know that the regulator is looking at us as well on innovation and research as well. You know, so again, why would you not be involved? The regulator's looking at this. Is why are you not involved? And I think to try and move yourself from good to outstanding, you've got to do a bit more than just everything that everybody else does, and you've got to kind of push yourself a bit more. And so I would say that to do a really good research project and really be involved and really care about what outcomes we're trying to get, that is outstanding. And that's what we're trying to achieve, is kind of leveling up all the time. And I think we should do that, and the regulator will look at that as well. But the other thing interesting, I was at one of our team meetings last week, and one of the night team members was saying that one of the children's school had DMV outbreak in the school. And she said, these are the kind of things we can check with Vivaldi, you see, because if we know DMV is in the area, then we can actually have that data. So then we can make decisions. And then she said, well, because then I bet it's in the hospital too. And then there was all of this discussion going on about from school to hospital to community to care home. And that's the stuff and we wouldn't have that. That wouldn't have even been a thing without this. So I think that's the thing. Anything that we can help to kind of prevent infection, whatever it is, knowing what is going on in a local space and having that data is going to make such a difference, you know. And we've learned a lot already, but there's so much more we can learn. It's quite exciting.
And I think what's really great about it is that everybody's involved, you know, everybody. And that's not always the case, is it? Some people don't feel, as I said earlier, that the voice are heard. And I always remember reading, and it was a quote, and it was Confucius. And he said, tell me and I'll forget. Show me and I might remember, but involve me and I'll understand. And it always stuck in my mind. And it's absolutely true that once you start involving people, not only do they understand, but they're also, like you've witnessed by going into care homes, they're coming up with, people want to be involved. They want their opinions shared. They want to, you know, to be able to say what they're feeling and have their ideas listened to. And I think this is such a great way of bringing it all together. I just feel really excited about it.
Me too.
And I guess that's where the collaboration comes from, isn't it? It's not, you know, we've spoken about actually it's not just one-sided being done to social care, it's social care giving back as well. And I think I'd written down around relatives when you were talking earlier, Sam, because I was thinking in my head, Diane, I think even when the caring view, before it was the caring view, I remember sitting on so many Zoom calls with you talking about actually it's not the relatives that are bringing in the infection, it's the staff, because they're going home to their families and the kids or whatever, and then they're coming back in. So I guess for you, it was probably music to your ears, actually, somebody finally saying, and researchers saying, actually, it's not relatives, because it was everything back in the day that you were campaigning and arguing for.
Do you know, it was not because, and this wasn't a slight at the staff, because I think as we were campaigning to get in, we didn't want to be seen as knocking care homes, because we knew what they went through. You know, I couldn't have done it. And like I've said this so many times, but I can't imagine the sense of loss that they had to experience. So it was never about that. But when the restrictions eased, it was obvious, wasn't it, that, you know, carers, I remember when it was announced that they could then go on holiday again, go abroad, you know, and they could go into restaurants, eat out to help out, or, you know, and you can imagine from a relative's point of view, like we couldn't even see our mother or Jenny's mum, my mother-in-law. And yet and not even if people were like going abroad or going into restaurants, I'm sure many didn't, because they did want to keep the residents safe, but they were going home to their husbands who were working, who were also, you know, it was so irrational, the whole guidance thing. And we just couldn't believe that was okay. And yet we were witnessing loneliness and isolation and deterioration, and, you know, and nothing were being done about that. And it was just so wrong. And the irony was that, and I can't speak for all relatives, because not all relatives are the same, just like not all care homes are the same. But certainly Jenny and I, we never moved out of our house. We had online shopping delivered. You know, we would never have put anyone at risk. And we felt like, gosh, we're probably we'd not been anywhere. And we were prepared to wear all the PPE and the masks, and it was absolutely heartbreaking. But we didn't want to be seen to be pointing the finger at staff, even though we knew this, because we relied on them to look after our loved ones. And I'll never forget what they did. And certainly in Jenny's mum's home, the carers were amazing. They really were. And, you know, we'll never forget that. But we just wanted just one person to be able to, you know, go in and spend time with a loved one.
I mean, I don't want to hijack the whole thing around COVID, but just touching on what you did, Diane, because we worked quite closely during the entire pandemic.
We did.
And we did a lot of work, and there definitely was that finger pointing, and there was the isolation of care homes. But there was also, and I speak coming from the LGBT community, so we had, and fortunately, I'm young enough to not have gone through the AIDS crisis in the 80s, and I don't recognize what people went through. But there was that stigma during the AIDS crisis that actually being gay bred HIV, bred AIDS. And during the pandemic, we saw something very similar with care homes being the sort of where COVID came from. And I will always remember calling a paramedic out, and they came in hazmat suits.
Yes.
They came in suits, top to bottom, with air tanks on the back. We need this for our own protection. We can't take COVID into other people's homes. So, like, I'm really, really sorry. We don't have COVID in our home. Haven't had COVID in our home. We don't produce it in our homes. But care homes were looked very unfairly. And it was this idea that we were creating all of the problems. We were creating all of this disease. Relatives were going to bring it in. We were creating it in the homes. It was a horrid, horrid experience. And one that I wish we could forget, but I don't think we should. I think we should always remember what went on and really learn from that. You know, external providers, stakeholders, regulators love lessons learned. There's some huge lessons learned here that I think we need to carry with us for a long time. I just want to say a thank you again, Diane, for everything you did during that time. It was essential.
Well, thank you to you two as well. And I think what's really nice now is we're all working together.
Yes.
You know, and it's just fantastic. You know, we're trying to work with managers to get relatives and residents meetings set up, and we've already had one meeting. We've got others planned. But honestly, the ideas that are coming out of it are just amazing. And I think, you know, we've come so far from being so far apart to coming together for the greater good of everybody. And that is just amazing.
Yeah. And just for me, I think moving forward, there will be another pandemic.
Yes.
there will be something that comes along, and I think that this time we'll be more ready. We'll be more ready with data to be able to make decisions earlier. We'll be able to push back, because I think a lot of us felt that it wasn't going in the right direction. We felt that the legislation wasn't okay, but we hadn't got anything to fight with. All we had was the NHS is overwhelmed, and you've got to do you've got to do what you've got to do. But I think we'll be much more equipped next time to be with data, and that's where this comes in, is to be able to kind of switch this on and kind of go, okay, well, this is the situation here, and we'll be much more informed than we ever were back then. I think you're right. I think we would in a way love to forget it, because it was exceptionally painful, and I think we went through hell. But I think let's not forget it, because actually it makes us better today because of that. So this is and for me, I always say, like, we started like pushing a juggernaut up a hill during COVID, and now we've got to push it over that and keep it going, because it started. So why would we stop now? That's why we need to keep this going.
And I think as well, when we talk about sharing good practice, because Laura alluded to it, and I think Sam did as well, that if a home, and Adam and Mark, I think we've talked about this before as well, haven't we, that if a home is having a high number of UTIs or, constantly getting, then why are they getting that and another home's not getting any? We've got to have that data so that we can analyse what's going on there that's working and what's going on there that's not working. Can you believe, if I was in a care home now, I wouldn't even need you wouldn't need my permission. I'd just be saying, do it, take it, because, we absolutely need that. How can you learn lessons unless you've got a starting point and a way of measuring it and moving forward? It's crazy. I still can't believe that wasn't the case in the first place, but thank goodness it is now.
No, absolutely. So we've spoken about, obviously, the word data, and Sam, you spoke about actually taking that juggernaut up the hill. And I think inside that juggernaut is all this data. And I think the pandemic accelerated social care to go digital. We know that. And there's a lot of providers out there with a lot of data now, don't necessarily know what they're doing with it. They don't utilize it. I know Adam and I have spoken about it on here before, about the worry that actually if you're capturing data and you're not utilizing it, what the inspector might say. How are you encouraging providers to utilize their data that they've got, and how are you kind of getting that out of them into, obviously, the research projects? I don't know who's best to answer that.
Do you want me to?
Laura,
shall I start? Yeah. Okay. So what we're trying to do is to make this as easy as possible for providers. And so we're starting really simply. So we're starting off just pulling one piece of information from providers so that we know we have accurate information on who is in a care home. And then we're linking to mainly health outcomes. So things like hospital admissions, vaccinations, antibiotics, those kinds of things. But we also really understand that is only a small part of what we need to know. And what we really want to know are things like quality of life. So how are outbreaks impacting on residents and their families? What are the financial implications of closing a care home for the provider? Those things are much harder to measure. But what we want to work towards is starting to think about how we can get measures of those things too. So we don't want to scare people. We don't want to sort of go in and say, right, give us all your data. We want to start very simply, build trust, make the case for why we need these things, and then think about how we can get them. And some of that will be possible to pull from the digital care records, definitely. And for other things, we may need to look at adding new ways of measuring in, maybe once a month or that kind of thing, so that we have got good data on people's quality of life. And then if I really go off-piste with my kind of university hat on, things that I'm really excited about are with AI. There are so many opportunities to use new technologies. And you could imagine you get a resident to say, hi, or how are you feeling today? And you could look at how they modulate their voice, and that tells you if they're happy, if they're having a good day or not. Or you do something similar with an image. You look at their face and you can tell, are they happy that day? Or is it? So I think that there is so much that can be done to be much broader in how we measure what's important. And we're just really at the start of that journey.
No, thank you very much. And Mike, did you want to come in and
Yeah, just briefly to kind of look at it from the other side. So Laura's done a beautiful job there of the academia, and she's absolutely right in saying this is as easy as it gets for care homes to take part in. We're using digital providers, so we're starting up with two digital providers who already have the data within their system. They already have NHS numbers held within their systems, and all we need is the transmission of those NHS numbers into the NHS database for, as Stephen described beautifully, anonymisation. That's actually the only ask we're giving to care homes at the moment. They actually don't have to additionally type anything into their care plans. They don't have to put any additional information into their systems for us to be able to get this data out and what we need at the moment. And I think that's a really important thing to kind of explain, because at the meeting last week, the guys there really just couldn't understand that was just how simple it was. Just literally ticking a box in their digital provider software is all they need to do. That's literally as hard as it gets at the moment. And the grand scheme is that we introduce this, it all goes beautifully, and it's just a drop in the ocean to where we actually end up in 5-10 years time. But we're starting with the absolute bare minimum for them to be able to really engage and get on board and see some proper results from really some fairly easy steps.
Thank you very much. And listening to you say about the care plan there and ticking the box for shared records, straight away in my head I was thinking, what about somebody that lacks capacity? What happens there if you've got somebody that there are concerns around capacity or doesn't have capacity, or there's family that disagree? What kind of happens there? Because I'm sure obviously the majority of care homes that you're probably working with are obviously the older persons, I'm assuming, just assuming that, but it might be completely wrong. But
shall I come? Yeah, I'll take this one just to start with. So it basically, rights don't change. Absolutely, at the very heart of all of this, everybody has the right to opt out. That is absolutely without question. Someone who lacks capacity, the people that would make that decision, their health decisions would be the people that would be making that decision for them. It's almost exactly the same as the care planning process that will currently go on in care homes. So anyone that you currently go to for the consent for all of the care needs of your resident, that's who we would be going to for this question as well. And of course, if there are any worries, concerns, etc., or people don't want to take part, then there is the ability to opt out. People's rights are not impacted by this at all. So it's the same process essentially.
Can I come in? Can I come in very quickly? I think taking a step back, and this is something that I found really difficult at first to understand, because it's something that I've never known about in adult social care, is the CAG application, and actually how we're able to do this project without consent and have people opting out. I don't know whether, Laura, you wanted to talk about that a little bit.
Yeah, I can. Yeah, so I'm not surprised you didn't know about CAG applications. So who wants to know about CAG applications? So at the start of this project, so during COVID, we were able to collect data without individual consent because it was a pandemic. So that was allowed. Normally, obviously, you can't do that. Normally, if you want to collect data from people, you get their consent to collect that data. But obviously, the massive challenge in care homes is exactly as you said, Mark, all the issues around capacity. And so our big concern was that if we said we will only collect data from people who can give us informed consent, that automatically excludes a very large proportion of residents. And the problem is that if they are excluded, then they don't benefit from what we find. And so we're not being inclusive. And so this is sort of debate about, do you have to get informed consent, or can you have this opt-out approach where you're trying to benefit everybody and you think that the benefits definitely outweigh the harms? And so if you want to go down that road and get opt-out consent rather than opt-in consent, you have to go through this legal process called CAG, where you apply to the Health Research Authority Confidentiality Advisory Group. The form is about 50 pages long, and you have to provide evidence to show why your case is strong, why people in care homes think this is appropriate, and how you've talked to them, evidence that. So we did a lot of work to talk and discuss, to talk to people, discuss this in detail, and really make sure that what we were proposing was acceptable. And so we have approval to do that. And so the approach we have is we have a lot of material. So you've seen our animation, we've got posters, we've got leaflets, and we have information at lots of different levels. And so this will all be displayed in the care home to make it absolutely transparent what we're doing, to give people the option to opt out if they don't want to take part. But it means that hopefully most people will, and that most people will be able to benefit from what we learn. So I hope that made sense.
And I think having Diane and the people from a resident and relative perspective as part of the overall planning and constructing this, if you like, this has been given an awful lot of thought, and we've discussed a lot, haven't we, over the time, you know, and I think it's we will always work with how we work today. So if somebody doesn't have capacity today, we will go through that BI decision. We will have all of that there because it's very important. But I think the opt-out option on here, initially we were all a little bit, oh, how's that going to work? Because you don't know what you don't know, you know. And true, we never heard of CAG. I never even knew. I didn't like. I had to ask what it even meant. I had no clue. But I think that going through that process as well, it's not given lightly. It's really it's a really thought through, considered way of you know, I was saying not given lightly. It just takes about 3 million pages to kind of confirm it, but it's hard work to actually get to that point. So I think we've established through that actually this is the right way to move forward. I think the other thing that blows everybody's mind is it's one number. It's like one number, one NHS number, nothing else, no name, no date of birth, no anything. By the time that, excuse me, I haven't got the your words, Laura, so I'm just going to say, as if it gets pulled into a washing machine before it gets put onto another system, it's completely cleansed. So you can never, the data that's held can never be put to Mrs. X here. Do you see what I mean? So it's completely clean. There was a big word we used, and I couldn't even say it, wasn't it? I can't remember, Mike. There was a word we used for it, but I can't remember. But anyway, that's kind of what we do. So it's cleaned, so you can't kind of assign it to to a human being.
I much prefer your way of laundering the data.
Because there was a word last week, and I was going, I can't even say that word. So we need to be able to
let's forget that one.
Word. So it was, I can't remember. Sure. But you know, so then I think it's like putting it in the washing machine. It comes out clean. You can't then, you know. So for us, that was really key. But I think that the key is here is that if we don't have the number of people with that data, it's not going to mean anything. So if we go to say the GP or NHS or whatever and say, because you're doing X, Y is occurring, and then we say, well, it's of 10% of the population rather than 95% of that population, it has very little impact. So it's really important that we make sure that actually works for the majority rather than the minority. But as we said, it's really easy to opt out as well. And you can opt out at any moment in time as well. So that's another thing. You can opt out at any point along the way. And I think when people hear, like, you know, when you think NHS number, the NHS use our numbers it's there all the time. It's in every day it's used. And that's with the NHS number that can be tied back to Samantha Crawley and where I live. As we said, once it goes through the washing machine, that can't even happen. So that is not very professional, the washing machine. I will think of something better. It's the only way I could think of to kind of put it across. But
it's set in stone now. That's it. Done. Yep. Done all the training. It's in everything I'm ever going to give out to anybody. It's fine.
It's going to kill me. But no, so I think that is it. So we need a lot of people involved because we have to get enough data to have an impact. And if we don't, then we won't. And that would be really sad and really bad, actually, for the future.
And just on I can't compete with Sam's washing machine, but genuinely, I don't think that we could make this work if we went for the opt-in approach. And one of the various people have said, well, can't we just put a box on the care record and just tick? But the problem is, for research, informed consent means it's a big deal. And so we would have to be confident that every resident had understood CAG or exactly what we were doing with it. And most people are not that interested in the details of data, and they don't want to sit there for half an hour and listen to a very complex. So there are a lot of reasons why it's really difficult to do it that way. And I think throughout the project, we're constantly checking in to say, is this okay? Is it acceptable? Is there a better way we could do this? So we're not taking it lightly at all.
Yeah, no, thank you very much. And I think actually for providers, and I know we spoke about it at the beginning about actually how easy it is. Actually, that just confirms how easy it is. It's just that number. So as long as they've gone through. So say you've got a care home that is on board and it says, actually, yeah, I really want to join this project. Sounds great. I really want to be involved. What are the next steps? Are there kind of any onboarding? Is there any training? Kind of what is there for teams and managers?
I suppose this is me again. I'm so sorry. This is where I come in. We've developed a free training program for any care homes that are interested. So let's take the onboarding process. If they're interested, then they can email us at info@vivaldisocialcare.co.uk. Anyone that wants to get on board with this, please do email. We're more than happy to speak to you and take you through things. Once that's happened, we will allocate you to a training event. They're going to be happening on a roughly monthly basis. It's about an hour and a half's worth of people's time online, though we are thinking about going out to visit regions at the moment. We're kind of in the development phase of that. That's kind of hot off the press. At the moment, everything's online. And we've developed the training with digital social care, skills for care, UCL and NIHR. So it's a real, again, as I mentioned earlier, this co-production of the project itself has carried forward into the training, and we've brought as many people from the sector on board as we could to really make it relevant for the care homes that we're trying to train and make it friendly to them. These are the people that they see every day in their training, so it fits with what they would normally be seeing. It's a really informal, interactive, as much as it can be online, session that we have, and we invite questions from people, and we invite them to challenge us on the consent issues, because let's get this right first. If people don't understand and they're not comfortable with it, how can they possibly explain it to their residents? So let's get that right, and we really make sure that people truly understand, so that they can get the whole concept across to people, and really empower residents to become a whole part of this project. It's just, it's really great. And we've conducted, so far we've had one training session and one care home visit, and both have gone really well. Really nice feedback so far. We're looking to build on that into sort of February and March at the moment. So yeah, anyone out there who's interested, please get in touch, please.
And can I just ask Mark and Adam, I'm going to put you two on the spot now, but as
I like this, Diane.
as previous managers in care homes, and having listened to what we've all said, what are your thoughts on Vivaldi? And is this something that you would have got involved with?
I'll go first and say that although I'm no longer a registered manager in care, I do manage nursing homes.
Yeah.
So I now support 4 nursing homes, and are sort of driving force at the moment. So I joined a group of nursing homes. It's no secret they needed work and we needed to improve, and we are doing now across the board, which is incredible. And we're seeing our ratings increase, we're seeing occupancy increase. Our relationships with external partners are increasing. But one of our main visions now is, how do we become a leader and innovator in social care? And we're not going to be able to do that. We're not going to be able to carve pathways and journeys and careers for people unless we do get involved in stuff like this. I would say my capacity probably won't allow right now, but it's definitely on our project plan moving forwards of what we want to be able to do. We're starting small steps by working with local training teams and clinical teams and actually getting them in the home and providing areas for local authorities and ICBs to provide training for social care. We're trying to create those sort of opportunities at the minute. I'm a John's campaign ambassador. I'm a full supporter of your work that you're doing. And that's another thing that I want to embed culture-wise. I just think in social care, there's a lot of work to do to lay the foundations to get people to buy into it, to really see the benefits. But I think if we go on ROI, which for me is reason, outcome, impact, if we start with the impact first and go, how is this going to enrich lives? How is this going to benefit people we're supporting? How is this going to make them live a great life and have a good death? I think once people get their minds around that, then they'll be like, oh, no brainer. Of course I'm going to get involved in this. It's just trying to get that sort of foundation laid. I just want to give a big up to domiciliary care as well, where home care has got zero data in research. I know we say care homes and nursing homes are poor. Domiciliary, you might as well not exist when it comes to research data. So I'm really excited to see what the landscape for research in domiciliary is. But yes, I definitely want to get involved in the near future, 100%. I don't think we can work in social care now with actually not being involved in stuff like this. We'll just get left behind and we won't be able to provide that outstanding level of support we want to.
Thanks, Adam. And you, Mark?
Yeah. So I now I don't work in a care home anymore. I work in reablement, which falls kind of under the category of home care. I think kind of putting my old registered manager's hat on, managing the care homes, 100% I'd be behind this. I think, anything to help deliver better outcomes for people, whether it's in your own home or up and down the country, actually, that's something we should do. I think we do have lots of data. It's just that we don't know how to utilize it. And I think actually this research allows you just to share somebody's NHS number really easily with their consent. And actually that data feeds into obviously the wider project that actually can then benefit so many people. So I think for me, it's a no-brainer. I think the question for me is, obviously, I'm reablement and we have a lot of data that feeds into the NHS around that bits and pieces. But home care and learning disability services, who is the project open to? Will it eventually be open to home care? And are LD services, mental health services that are within care homes and supported living eligible as well?
I think it's a really interesting question, actually. So at the moment, we're in the initial phases. We've had so much interest. Within the first 6 months or so, we had over 800 providers contact us. To make the pilot work, we're going slowly. So phase one, which was the first training, we're using providers who are using Nourish and PCS because we need to get the system right. Throughout the year's pilot, we're going to be onboarding more homes that are using other digital systems. So we've got a waiting list of homes waiting to join the pilot who are using other digital systems. The project currently is just for older people living in residential care, but from day one, we've had people from LD services, domiciliary care saying, actually, can we have something within our remit, our sector? So we're actually building up a waiting list, and I think as this project works, I think the world is our oyster. This is a pilot. We want to try and get the model right, and if we get the model right, I think the project could be expanded out a lot wider if we've got people like Laura taking that forward for us.
No pressure, huh?
And I guess that's the thing, isn't it, with social care, we're also time poor because we're spending all our free time on the staff and the people we support. So no, definitely welcome it kind of going out to other parts of the sector. I think that'll be fantastic. I think it's great that you've already got that waiting list. And if there is anybody that is thinking, actually, I want to be involved, I'm a home care provider, do you recommend that they register? And I did share a forms link where people can easily register. Would you ask them to register their interest? And you've got that right now.
I would say definitely register your interest, because even if it's not part of this project, the OS actually is focusing on research across the sector, and lots of different researchers are contacting us saying, actually, we're doing something in domiciliary care. So if people have registered their interest, we can put you in contact with other people, any other projects that come up. So it's always worth doing that.
And the OS, as directors, we've got a director who mainly runs LD services, and we've got a director who runs home care, because we kind of cover the whole of the sector. It's not just care homes. So I think it's really important that people do contact us for all those reasons, really. And I'd just like to just go back really quickly on time. Actually, if a care home joins now, the team members can join the training, and they're loving the training, by the way. They feel very special. But also, if you think about your IPC and how you're managing infection prevention and control in your homes, this is another piece. It's another tool, and you're teaching your team members you're giving them another piece of tool for their toolbox, if you like, as well. So I think, I think team members, although there's a little bit of time from team members for the training, once this is up and running, it'll be up and running. And then it will become part of the culture and part of the veins of how places work. So I would just like people not to think it's going to take a lot of time, because it's really not. That it's literally being created to stop time being taken away and to use data instead. So hopefully that kind of gets that across.
Thank you very much. Adam, when they said PCS, I was thinking Adam uses PCS. Oh, you're on.
I do. I use PCS, and actually, I'm gonna tell you a secret. I used to hate PCS. I used to absolutely loathe it when I was a care home manager. Now that I'm not using it as a manager and I'm using it for other things, I can see the beauty of it, and it is amazing. Like, you can do so much on it, and now that I can support my managers and going, if you click the button, you get all of this. And I'm like, oh my god, wow! I'm like, I know. But even for us, the key is we don't want to overload our teams with so many new initiatives and so many projects. So a lot of the stuff we're going for, we're getting that integrates into PCS. So actually it all talks together and it all communicates together and reduces that risk of either duplication or triplication in some areas. But makes it's something that you can look at and go, oh, I can see how that's working now. I can see what I've put there is fed into there, and the outcomes here and the impacts there. And it's wonderful. So I know I love it. So I use PCS. I will be having a conversation with you all at some point around getting a project plan in place of how we can get this implemented in our services.
Thank you very much. Well, I'm very conscious of time in your evenings and the viewers' evenings. Sorry, one last question from me. Does it matter whether you've got a requires improvement, whether you're a good service, whether you're outstanding? Is it open to anybody regardless of rating and size of service?
Absolutely. So we often forget to say, so the Outstanding Society is free to everybody, irrelevant of your rating. If you want to improve, if you want to share best practice, come and join us. Just click the contact us form. You'll get newsletters. You'll be invited to free events. You'll hear about all these different projects. You'll hear about the Outstanding Diversity Forum that Sanjay is leading on this year. So lots of exciting things going on. Doesn't matter what rating you've got. Just come and be a part of it all.
I was about to say the only downside of joining is you got to put up with Sanjay, haven't you?
Yeah, but we quite like him, so
I'm joking. We're huge Sanjay fans at the Care Review. We do love a bit of Sanjay. Oh my gosh. I can't believe it.
He's in Mumbai now. He's in Mumbai at the moment having a ball. So yeah.
Having a ball, buying shoes, most likely.
Definitely. Definitely.
He's probably walking around in Crocs, isn't he, Mark?
Oh, for sure.
Sanjay loves Crocs. So
he does have a Croc.
So if anyone wants to buy Sanjay a present for his birthday or any of the holidays that he celebrates, just get him some Crocs in the most obnoxious colours you can find. Buy him some Crocs.
I love it.
Very, very quickly, we've just had a comment come in. Is it available?
It's not from Sanjay, is it?
No, it's not. Is it available across the whole of the UK, including Scotland, or is it England only at the moment? Or
England only at the moment because of how the data works. Yeah. But we are talking to Scotland, certainly. To people who are working on similar things. Yeah.
Thank you very much.
Perfect. Right. Well, first show of the year done, and I know we're pretty much booked up for the first half of this year now, which is incredible. As always, huge thank you to Mark for the effort he's putting in behind the scenes and getting all of our shows booked and arranged and putting them all together. I show up and wing it every single week. You know, I'm a bit like Holly Willoughby, doesn't know really what's going on. I just show up and speak and then go away. Probably say something that's going to get me in trouble and then laugh. But no, it's been an absolute pleasure being back this year. An absolute pleasure having this show. It's been really, really fun, really great to learn and listen about Vivaldi. We will make sure that links to the Outstanding Society, Vivaldi, the research, care rights are all shared in our social media posts alongside the catch-up of this episode. If you do want to get in touch with anybody from the show, please do go follow us on social media. Go to www.thecaringview.co.uk where you'll find all of our information, our podcast, our episodes, our free resources, our CQC hub, and we have a new set of hubs that we're looking forward to introducing over the next 12 months. Please bear with us though, because we're going to try and be technical and upgrade the website. So it may just like go out of action for a while. And if it does, we're still around. Mark and I are just troglodytes. Thank you everyone for joining us this evening. It's been an absolute pleasure. I hope you've enjoyed it. Open invitation to come back in the future to discuss anything that you possibly want to. But until then, stay safe. Thank you very much. Happy New Year. It can't be too late. We're still in January. Let's keep saying it. And we will see you next week. Mark, what are we discussing next week? This is where I put Mark on the spot now.
No, I was planned. So we're actually being joined by somebody that's been on our show before, Jane Connery, who's coming back to talk to us about CCTV in social care. Jane's been on a campaign for a number of years now about the benefits and the importance of obviously CCTV and how it can drive down kind of safeguardings and bits and pieces and utilising some of that data, from surveillance around calls and how you can put things in place. So we're going to have a catch up, see where she is with her campaign, just hear some of the positive things that she's done and achieved, and some of the services that she's working with and what they've found. So really looking forward to kind of catching up and seeing where she is with that. So, and hopefully I'll be listening early. Hopefully we'll be able to invite you back at the end of the year or beginning of next year to see kind of where you're at and what the data is showing us. But yeah, please do keep us updated so we can.
And can I just say as well that I think you two have done such a fantastic job. I'm not just saying it, what you've done with Care in View and the audience that you've now got, and also you're giving voice to subject matters that are so important. And I think it's fantastic. So well done you two as well.
Thank you so much, Diane. Please do join us next week. And I'm going to be probably going to get in trouble for this now, Mark, so tell me off later on. If you don't agree with CCTV in care homes, do join us next week. It'll be good to have that conversation. We want to hear all opinions about what's going on. Love a bit of a debate. Let's get some conversation flowing on that. So, yes, before we keep you any longer, go and enjoy your evenings. I don't think there's anything good on a Tuesday night at this time of year, so you're probably not missing much. But go and rest. Enjoy your wonderful world of social care, and we will see you next week. Take care, everyone.
Thank you so much.
Thank you.
Bye. Bye. Bye.